Hello everyone, and thank you for joining us on this session of Doc is In. My name is Dr. Naghma Nawaz. I'm a breast radiologist at Cleveland Clinic Abu Dhabi. We're going to talk about deep dive in breast imaging. We are at Arab Health Congress, and we have just started the conference Total Radiology, on which both myself and Dr. Asiya Khan was speaking at. And we thought this is a good opportunity to further discuss the same topics in this broadcast. Now I'm going to introduce my colleague, Dr. Asiya Khan, who's also a breast radiologist at Cleveland Clinic Abu Dhabi, who works on daily basis with me.
Hello everyone, my name is Asiya Khan. I'm a consultant breast radiologist currently working at Cleveland Clinic Abu Dhabi, and it's a pleasure to be here on Arab Health. And yes, as you mentioned, deep dive in breast imaging. Let's go ahead and crack the topic, Dr. Nawaz.
Great. So we are going to talk about certain parts of breast imaging. So I thought we will start by talking about screening for breast cancer. Which modalities do we have choices with, and when do we use them? So shall I get you to start?
Sure. So the way it works is we follow the American College guidelines, and at Cleveland Clinic Abu Dhabi. So we start screening usually at the age of 40, where we do annual mammograms up until the age of 54. On the 54th birthday, when the lady has a mammogram done, she then comes once in 2 years after that, and then she has a biannual mammogram basically. And this is when their ladies are normal, asymptomatic. They just walk into a GP or a doctor or any of the healthcare practitioner, and they book them for the screening mammograms.
So as Dr. Khan said, we start screening from the age of 40, and we do it till the age of 55 every year, and then we drop it to every 2 years. So that's the normal modality we use for screening, as we all know. Now, on the topics we were talking in the Arab Health, so when other modalities are also being used for screening, so part of it is MRI breasts. So it's the hot topic. It's where do we use MRs, which patients shall we use it on for screening MRI breasts, which scenarios. So that was the topics we were discussing it in the Total Radiology. So we're going to just talk about, we'll shed some more information about that when is MRI used in screening for breast cancer. So shall I take a start? So one of the scenarios which most people actually already know about is that screening MRIs can be used for high-risk patients. And what do we mean by high-risk patients? There are many models available in the market. But the most commonly used, and definitely used at Cleveland Clinic, it would be Thyroid-Cuzick model, which helps us assess the risk factor into the model, and then gives us a number of percentage of what is the likelihood of this particular lady to have breast cancer in a lifetime. Most studies would say that if the risk is about 20% or more to have a cancer in a lifetime, that's when MRI breasts can be helpful and should be added on. And of course, there are many high-risk factors such as genetic testing, where they are labeled as we all know, that BRCA1 and BRCA2 would be the highest genetic mutations which get screenings done. And there are many other genetic markers which also help us to decide whether the patient should be put. So I'm just going to get Dr. Khan to talk about how do we screen for high-risk patients at Cleveland Clinic Abu Dhabi.
So what we decide to do is, as you mentioned earlier, we go through this tests which the doctors tend to do them in the clinics, and then they do a risk assessment score. Then we bring them down according to their cycle timing. We need to have them on the correct time of the cycle. And we bring them down and have an MRI done annually. And in between, what we do is we try to stagger it with a mammogram. And say, for example, if she's having an MR done in January, then mammogram is due in June, and following which again she has an MRI in January. So that's how the cycle kind of continues and follows up. If we see things which are different in comparison to the previous, then we bring them up again, have a look, and then take it from there.
We're lucky at Cleveland Clinic that we have the luxury to have a genetic counselor in-house. We have a high-risk breast clinic where we have specialized people who are fellowship trained to deal with high-risk patients. And so we get these patients picked up and sent to the genetic counselors, sent to the high-risk clinics, and they do all the assessments for us. And then we are asked to screen them as a high-risk patient. Very seldom it would happen that we would pick them up ourselves when we are reporting a screening mammogram ourselves, and suddenly we realize, as per the questionnaire, that the patient is falling into the high risk. So again, we can just refer the patient to the genetic counselor or the high risk clinic and let them reassess the patient and decide which pool they get into. So it's a very nice and smooth system where, you know, it's a very good collegial system between the breast clinic, different physicians, where we can just pick up the phone and just send the patient over whenever we need to, and they can do the same whenever they need to. So the other topic of where MRI breasts should be used, which was being talked about today as well, was where it's dense breasts. So dense breasts is a newer topic which is being looked into, that when can we start screening dense breasts, and what do we do and how do we screen them? How often do we screen them? Can we use an MRI breast or not? So what are your thoughts about it?
So I think that is where the question of fast MR comes in. That is what we are, again, lucky enough, blessed enough to get that protocol sorted, get the system into action and get the fast MR done at our facility, so that the more we see, the more we do, the more we learn. And hence I feel that yes, when it's dense breast, we can it can be tailor-made screening then for each single patient. Then if there is a dense breast, then the patient can go for a fast MR, so that we don't miss out on any lesions which by any chance we were going to miss with doing just a basic mammogram. So that's what I think it is. And
I mean, fast MRI is a really good way to go into MR screening, is because one of the reasons patients don't come back to you as often as they should is because of their experience of how long they were in the scanner, which can be tedious, which can be uncomfortable, and then they avoid coming back to you. And the second point is also sometimes the cost of it, that, you know, patients who are self-paying, they would find it expensive to get an MR done every year. So the fast MRI is helping us on both fronts. It's helping us by reducing the time duration for the scan, giving us almost similar information which we would have gotten from the full protocol MRI. And it's also reducing the cost. And as you said, we are lucky that at Cleveland Clinic Abu Dhabi, we have been able to start this program of fast MRI, where we are offering a much reduced rate for that fast MRI, which should be done within a fraction of the time, so which would be less than 15 minutes, possibly more likely towards 12 minutes of scan time versus a 40-minute to 45-minute scan time for a full MRI. So I'm really looking forward to offering that, you know, on regular basis to everybody, as we've just started it. And I'm hoping that our patients coming back to us, the number will increase, as well as the word will spread, more and more patients will come to us because of that service. So now I'm going to talk about, or start talking about that, what about the breast biopsy options we have at Cleveland Clinic Abu Dhabi. Again, blessed with almost the whole range, but I'll get you to talk about it.
So we practice a wide variety. Again, it is very, very tailor-made depending on what the patient has come with to a clinic and which modality do we best see the abnormality. Everything depends on that. It's not just like one age, one size, one imaging. No. So if the patient is definitely more than 30, we then tend to do a mammogram and then do an ultrasound, and then we pick up lesions on that, and then do they need biopsy or not is another call, because we have the radiologist sitting there at that point in time. The images get reviewed and the radiologist decides what has to be done the next step further. And if need be, we then talk to the surgeons. If it's so urgent, we then tend to do it ASAP. Otherwise, if it can be booked on a list, we then tend to bring them back and do it another time as early as we can. So it also depends. Then we also look at the breast, not just the breast and the axilla, and then also axillary lymph node biopsy is possible. So we can choose select imaging depending on the pathology that we are seeing there, right there, and then we have different biopsy options like ultrasound guided biopsy, by core needle biopsy, and then we have the vacuum assisted biopsy. Under mammographic guidance, we have mammographic guided biopsy, stereotactic biopsy, and I think very soon we also have the option of contrast enhanced mammography coming in. So we should be able to do biopsies under contrast enhanced mammography option if need be. We also follow the MR guided breast biopsies at our facility. Like if a lesion, I believe that if you are doing a modality or which you are trying to investigate, then I think we should be having a facility to biopsy in that particular modality, which touch wood, again, we have the option of MR, and hence we have the option of MR guided biopsy. If a lesion, usually we don't tend to straight away jump in for the MR guided biopsy. When we see something on MR which is new and enhancing, we try to bring them back with second look ultrasound. If we see them on second look ultrasound, because it's simpler method of biopsy, we try to biopsy there and then. And if not visible, then we definitely have the option of MR guided biopsy, following which we put markers into patients, take pictures, and take it further and do a post biopsy mammogram as well. Anything else that you think I should be adding off to?
No, you've covered it beautifully. It's just, again, we're just lucky that we're working at a facility where we have the full complement of all kinds of biopsies which we want to do. We can even decide on the day, we can change between the rooms, and we're doing an ultrasound and we're not sure that this should be biopsied under ultrasound. We can just take the patient into the stereo room and do the biopsy there. We have extremely experienced techs, whether it's mammography technologists, whether it's ultrasonographers, or whether it's MR technicians. We are comfortable doing the biopsy in any modality as per the requirement and whatever is more suitable for the patient. So we don't need to cut corners. We do what is required and what is ideal for that scenario and for that patient. As we keep saying that, it's just very, very blessed and lucky that we are working at an institute which gives us everything which is needed to practice in the best possible clinical practice.
And I think tomosynthesis guided biopsies make sure that we are more accurate and get to the right slice, right abnormality, and take the sample from the rightest place where the abnormality is located. So again, once again, we have that option available. If anybody is struggling, suffering, or getting a biopsy done and it's not rightly done, usually it happens that patients kind of visit different facilities, try to find the right doctor, it doesn't work with them. Then they end up coming here. We then tend to do a workup depending on what, we don't start the whole workup, right? We just end up doing what is required then. From where do we start is the question. So we don't start just saying, oh, let's complete the whole thing. We try to ask them to bring their previous imaging, relook at those images, review them, and discuss with our surgeons and take it further from there. What is needed next is the option.
Yeah. And as you said, I mean, the uniqueness of the services we have are tomo-guided biopsies, which very few facilities would be doing. To my knowledge, we are the only ones doing in the state of Abu Dhabi. Which is an amazing service to have, because the accuracy, the ease, the speed with which the same biopsy can be done under tomosynthesis guided is much different than a regular stereo biopsy. And then one of the things which we have and we are very proud of is the lateral arm approach, which makes it more comfortable for the patient. It also expedites the processes. The biopsy becomes much quicker and much easier. And we finish the process and we're done.
I take pride in saying that there is no lesion we cannot biopsy. There is always a possibility that we can biopsy it one way or the other with our lateral arm approach. Yes. I think we're proud to say it once again.
Yes.
And I hope we keep continuing to say that and improve in our practice.
Yep, yeah, exactly. Again, the same thing, we do so many of these biopsies on daily basis that the workflow has become so easy and efficient that our biopsy times are getting reduced and more reduced and more reduced. It's just the sheer number, which helps us get the experience and become faster at them, which becomes more comfortable for the patient. We also have the pathology in-house, and another unique feature, which means that we can talk to the pathologist, we can even call them and expedite, we can put a rush on it, and if they're stuck with something, they can just call us and they can ask, what do you think is there? And so it's an amazing interactive process throughout the journey of the patient, which is happening in the background. The patient doesn't know it, but all of us are working in conjunction with each other to make this happen. So, and then of course we have the tumor board where we discuss all the cancer patients or any complicated cases where we need further input from the different subspecialties to sit together and decide and make a decision what needs to be done next. So,
including the plastic surgeons, I think the genetics team, the plastic surgeons, the oncologist and the radiation oncologist, it's a complete set of package for breast care. So yeah, we definitely do take pride in saying that we work at this facility and we look forward to seeing you all there if need be. God bless.
To conclude, after all that technical information, what I would like to stress upon is, from a woman to a woman, please get yourself checked. Get a screening mammogram done. It's essential for you to take care of yourself because you are taking care of your entire family. Please come and get your mammograms done because it's essential to find a cancer as early as possible. It saves lives. It decreases the burden on you and your family, so better to get checked.